Hello and welcome to AT2 HNN318, Care of an Older Person, the case study on Elizabeth Sadler. Elizabeth Sadler is an 81-year-old who has been experiencing increased mobility difficulties with 2 falls in the past 3 months. No injuries recurred. These incidents highlight the need for her to assess her musculoskeletal health and safety within the home environment. A brief overview of her history include osteoarthritis, which is a degenerative joint condition causing joint pain, stiffness, and reduced mobility, hypertension, long-term high blood pressure, type 2 diabetes, which is her body is less responsive to insulin and progressively loses its ability to produce enough insulin. Due to her age, Elizabeth is likely experiencing age-related musculoskeletal changes, such as sarcopenia, which is the loss of muscle mass and strength, which affects 1 in 5 Australians over 60, reduced bone density, which leads to weaker bones and higher falls risk. By the age of 80, muscle strength has declined up to 40%, which affects balance and function. These changes are clearly impacting Elizabeth's functional independence, as she may have difficulty climbing stairs, rising from a chair, and completing household tasks safely. Reduced mobility and recent falls reflect likely joint stiffness and weakness in the leg muscles. About 25% of people aged 65 and above experience 1 fall each year. Elizabeth lives alone in a unit in the back of her son's house. Although she receives fortnightly home help, this may not be sufficient given her physical decline and falls history. In summary, Elizabeth's musculoskeletal decline, combined with her chronic conditions and limited supervision, significantly affect her ability to live independently and safely. These factors must be considered as part of a holistic care plan, especially now that she is experiencing delirium. The 4-AT tool is an assessment used upon hospital admission. It is a rapid bedside screening for delirium and cognitive impairment scored from 0 to 12. And 4-AT examines 4 domains: alertness, abbreviated mental test, attention, and acute changes. Elizabeth's assessment findings are her alertness. Elizabeth drifting in and out of sleep while you're talking with change, which means abnormal alertness. Abbreviated mental test. She is asked a simple orientation questions: her date of birth, her age, her current location, and what year she is in. Elizabeth is unable to answer most correctly. She can say her date of birth but gives her age incorrect, and she does not know where she is at the currently and what year it is, which scores her at a 2. The attention. This section, Elizabeth is asked to list the months of the year backward, which is a task that most alert adults can do. Elizabeth is unable to remember any months, and she is unable to perform this task, which scores her at a 2. There is the acute changes or fluctuation. This section asks if there's been any significant changes or variation in her mental function, alertness, and cognition. Sudden changes from baseline, which is a yes from Jane's account, which gives her a score of 4. Overall, she is scored a 12. The interpretation of the assessment is that Elizabeth has acute confusion with inattentive and disorientated. Findings are consistent with hyperactive delirium. Hyperactive delirium is characterized by heightened arousal and activity. This can present as a patient becoming aggressive, agitated, restless, and may have rapid mood swings or hallucinations. Hypoactive delirium is characterized by reduced motor activity and lethargy. This can present as a patient being sleepy, withdrawn, and quiet. This can be mistaken as depression or fatigue. In Elizabeth's case, she is more fitting with hypoactive delirium, as she does not experience any hyperactive features. In terms of risk factors, one important predisposing factor that for Elizabeth's case is her advanced age. As the brain ages, the brain reserve diminishes and is more susceptible to acute stresses. There is also a reduction in the neurotransmitters in the brain, which are important for cognition. Her advanced age also makes her slower in homeostasis regulation. Advanced age makes the brain and body less resilient, Even mild stresses that a younger person could tolerate, such as a small infection or a poor night's sleep, can trigger delirium in older adults. A precipitating factor is that likely triggered Elizabeth's delirium is a confirmed UTI via MSU. When they get a infection like a UTI, the body can overreact, causing more inflammatory than necessary. This extra inflammatory does not fight the infection, it affects the brain, leading to confusion. This is due to the brain becoming less able to handle stress. An older brain is more susceptible and less protected, which makes it easier for something like a UTI to tip into confusion. Some non-pharmacological interventions include reorientation and communication. This helps ground delirious patients in reality and can shorten episodes of delirium. You can do this by speaking clearly, calling her by her name, reminding her where she is, who she is with, using large clocks, calendars, and familiar photos. Engage in conversations about her family, using her sensory aids such as glasses and hearing aids. Another intervention includes support her physical needs and early mobilization. Getting Elizabeth out of bed, collaborating with the physio to see if there's any gait aids needed for her to ambulate safely, sitting her out of the bed for meals, and also doing supervised short walks, as bed rest can promote deconditioning and disturb her sleep cycle. Whereas sitting her out of bed and walking with assistance can improve circulation, cognition, and sleep quality. Making sure that we do adequate pain assessments, as unrelieved pain can worsen confusion. Also taking into account her hydration and nutritional needs, as if they are not met, they can also prolong delirium. The last intervention is optimizing the environment and sleep. Making sure that during the daytime the curtains are open and the lights are kept on, and during the night there is reduced noise and the lights are off. Also avoid unnecessary alarms. Also making sure that her environment is safe for her, so make sure that there's nothing on the ground that she's able to trip on. These strategies address disorientation at the core of the delirium by continually bringing her attention back to the comforting reality. Evidence shows that such orientated focus interventions can significantly prevent or reduce delirium duration. Lastly, educating the family. Making sure that the family understand that delirium is sudden and temporary confusion and that it is not dementia, and it is reversible with treatment, as she will be undergoing the IV antibiotics. This is caused by illness, infection, surgeries, or medications. In Elizabeth's case, this is caused by a UTI. It is common for older adults to experience delirium, and that her symptoms are consistent with hyperactive delirium, such as disorientation, drowsiness, and fluctuation in awareness. The rationale for us explaining it to the family is that informed families feel less anxious. They can also help identify and manage symptoms early and reinforce consistent communication and routines. How we can engage Elizabeth's family? We can engage by bedside presence and also helping with orientation, so asking them to bring in photos and asking her if she likes familiar music. Also assisting her with feeding and mobilization if appropriate. Notifying staff of any changes and involvement in discharge planning.